I'm Dr. Yusof bin Abdullah. I'm based in Women and Children Hospital, Kuala Lumpur, but we use the other name is the Hospital Tunku Azizah. I'm basically a consultant pediatric surgeon in this department. I had my undergrad degree in National University of Malaysia. I graduated in 1997. And after that, worked as medical officer for 3 years. Then I joined masters in general surgery. So I graduated as a general surgeon in 2004. And then worked in East State Terengganu for about 1 year plus before I came back to Kuala Lumpur to further my pediatric surgery. That time, pediatric surgery is a sub, what we call it fellowship of general surgery. So I joined back in 2005 September, and then based in this hospital until now. I also had 1 year working experience in Red Cross War Memorial Children's Hospital in Cape Town, South Africa. Mainly doing general pediatric surgery and pediatric trauma and burns, and also had a few short attachments I did in Australia for the laparoscopy and burn, and also Great Ormond Street Hospital in London in complex urology in 2014. Well, so that's all briefly about myself. Basically, vascular access, we can divide into a venous access, the arterial access, and also intraosseous access. So venous access, basically, we use in anesthesia, patient undergoing surgery, or any fluid resuscitation, in critical care medicine where a patient in intensive care units, or if you did medication delivery for the patient and children, and also for basically in parenteral nutrition. So and arterial access, as we all know, is desired in major surgery where you need to frequently monitor the blood pressure monitoring during the long surgery, and also patients in basically intensive care unit, either pediatric ICU or neonatal ICU, where you need fairly frequent blood sampling and the monitoring of the arterial blood gases. And finally, the intraosseous access, basically in emergency situation where you can't get a peripheral access or central access because time is very limited, and that's why it's used in basically in arrest situation or peri-arrest situation. So that's the overall overview about this venous access. If we talk about let's say we talk about the elective surgery, so the peripheral venous access is required, especially in small children where before anesthesia they need to be fasted for minimum 6 hours. But these small kids, they couldn't afford to fast for that long, and they need like 2 to 3 hourly feeding. So that's why they need venous access. For that, you can give intravenous drips while waiting for the surgery, or any condition where the child cannot tolerate orally. For example, in the case of gastrointestinal obstruction, where the child will have vomiting, so they couldn't tolerate orally, so the child need to be kept fasted, and they require a venous access for the intravenous fluid. That's in general the indication prior to surgery, the insertion of venous access. For tunnel line, such as Sigmund Brovia catheter, basically is indicated in a long usage of the line. For example, a patient will be on chemotherapy. The patient will require some sort of like a bone marrow transplant, will require usage of central venous access, and also in the cases where these children with short bowel syndrome or bowel dysmotility will require a long-term parenteral nutrition. So that's the indication for the tunnel tunnel line. For non-tunnel device, basically indicated in more than a week, but probably it's about 1 to 2 weeks duration. For example, in patient that requires certain length of antibiotics, so short-term total parenteral nutrition, or patient is very difficult venous access, also might need this non-tunnel center where you can keep the venous access for duration 1 to 2 weeks durations. Because for this tunnel subcutaneous implantable port, also we can use for a longer duration of treatment, but in a kind of intermittent requirement, in long duration but intermittent access to the port. For example, in patient with hemophilia patient where they require some sort of a very long duration or insertion of a factor, or patients with intermittent parenteral nutrition also, and any patients with like enzyme replacement therapy. So we can consider in terms of inserting the port, the tunnel type venous access. Yes, even though in neonate especially, and in 1 week infant less than 30 days old, we prefer for the long usage, we prefer umbilical venous access. But in an emergency situation where, let's say, the child develop cardiac arrest, when the child collapses, you need to insert the line in very short time, a period less than 1 to 2 minutes. So intraosseous line is one of the best option. So it can, there's one paper from Neonatology Journal, the study done, it shows that they have inserted intraosseous line as small as 500 gram baby. So it can be used also in neonate for as emergency venous access insertion or usage. Unfortunately, I don't think there's an alternative to intravenous catheterization because you need to get the venous access. So that's why it's very important to for a person or clinician that is senior enough and experienced enough to insert the venous access. So in usual situation in the ward, for example, the medical officers in charge of the ward, maybe the medical officer can only try 1 or 2 attempts to insert the venous. Let's say we talk about the peripheral venous access. If they fail, they should call their specialist, which is the more senior person who have more experience in inserting the venous access. In patients where sometimes the patients with chronic patients we frequently admitted with a very difficult venous access, is known that this particular patient is difficult venous access. So they need to plan in terms of the venous access insertion. They probably need to use other devices which can help in terms of to get the venous access successful insertion, like using translumination or using ultrasound guided in detecting the vein and to insert the access device correctly and successfully. So there's no other alternative other than venous access. Complication can arise, and it depends on what type of venous access that being done in the emergency situation. If, for example, for peripheral venous access, a simple complication, especially when the patient comes in an unstable state where patient is dehydrated, so It's very difficult to insert the venous access. So end up with multiple attempts of insertion, which cause more pain to the patient. Patient can develop bruises from that failed insertion, and also extravasation, especially after we think the line is in the vein, and then after you infuse fluid or blood, for example, so it can extravasate. It can end up with bruises, and then edema, and then end up with necrosis. For central venous access, also can have, let's say this is non-tunnel central venous access, where in emergency situation the clinician inserted into, for example, in the internal jugular vein or femoral vein. So hematoma can happen, pneumothorax can happen if the line inserted in the internal jugular vein. Okay, if hemothorax also, if the hematoma become bigger, it can compress the airway, can cause respiratory distress. So also inadvertent arterial puncture also can happen, part of the in an attempt to insert into the central venous line. So for intraosseous line also can have extravasation. So it's very important to check whether the intraosseous needles is already in the marrow cavity of the bone. So that we prevent this extravasation, subperiosteal infusion, and then eventually probably later complication, patient can develop infection as well. So in very emergency situation, especially in a small neonate, small children, where if we are not careful, we can cause fracture to the bone itself during the insertion. Insertion of vein puncture basically is very stressful situation, not only to the clinician, especially to the patient and the parent. So I think communication is very important. We need to speak the same language to the parent, to the patient. Explain, if let's say is school-age children, we need to explain to the patient why we need to insert the line, why the line is indicated, and also explain to the parents so that both children and the parents, they understand well why the vein needs the venous access need to be done. So communication is very important. And I think because it's a very stressful situation for both. So with the presence of the parents with the patient is, to me, is very important. First, you must make sure parents understand, and then you need to inform them, explain to them how the procedure is going to be done. So hope the parents can at the same time can comfort the child, so that the child is more cooperative during the procedure. And we can also use other methods like distraction to the child, like video audio distraction method. We can just give cell phone to the patient for them to watch YouTube, video, cartoons, whatever, so that it distracts the child from feeling a kind of the pain and anxiety towards the procedure. So I think that one of a few methods that you can use to minimize the anxiety, and because it is a traumatic process to the patient and the parent. I think in terms of the tools and the instruments, I don't think there's such a pitfall, but the clinicians who's doing the procedure should prevent the possible pitfall that might happen. So that's why it's very important for the clinician to be quite experienced in especially inserting lines in younger small children or neonate. They must follow we as the clinician must follow the guidelines that provided for the procedure, and try to minimize the complication that might happen from the procedure and after the procedure itself. So so that with that guideline we can avoid the possible complication happen during the procedure insertion, and especially after where infection also can happen. So by explaining to the patient and the parent and follow the strict guidelines, hopefully this will minimize all the whatever possible pitfall and also complication on the procedure and the post procedure itself. So in terms of the nursing care of the venous access, sometimes so that because the especially during central venous line incision, where we hope that the catheter can last a very long time. So that's why in terms of the care, also very important to minimize all those complications, because we could see also complication could happen like a fracture of the line, infection of the line. So if the nursing care and handling of the catheter is done properly with aseptic technique, so we could minimize all the possible complications. And any signs of early infection needs to be treated promptly with antibiotics, and and check withdraw the blood for culture, so that we can treat the infection early and appropriate according to whatever organism they go. I think that's I guess it's more towards the patient and parents' anticipation when the procedure is going to be done. Of course, not you won't get all of your patients to be very, very cooperative with you with all the procedures. You will get on and off. Sometimes you get some kind of very difficult patient and parents sometimes. So that's why to me the communication is very important. Understanding of your procedure and especially when the child's management also very important. So the parents must be really explained so that they can understand the whole process, so that they don't think that we're not expert in doing the procedure. So, and then the clinician itself must be very experienced, so that and follow the guideline that you mentioned earlier, so that the attempts could be minimized. Single attempt, especially if you can get the single attempt, which is very good. But that's why and then when to do the procedure, I think you must do it in a team, so that you can have assistance to make your life easy during the procedure. Need to comfort the child and together with the parent that assists, so that the procedure will be done smoothly. When you have a good team and patients and parents understand well the need of doing the procedure, and I think they will be more cooperative with you. Especially in managing children is very I say it's very challenging. It's not like adult, and children also, they are not small adult. There are children that have different behavior, different physiology, different kind of presentation. So I think experience wise is very important before you want to specialize managing children. To me, you especially in pediatric surgery, and they must have some background in surgical base and experience in adult. For example, let's say inserting granula, venous access. So they must have experience doing that in adult before this embark on doing in children, because if never have experience before, to start learning in children is very difficult, because the chance of getting that experience is less compared to adult, and the chances to get the procedure done successfully also is basically higher in adult. So I think the training in adult, where you gain your experience in adult, is very important before you start doing in children. And when doing procedure, they must really follow the guidelines provided, and because this guideline will actually increase your chance of success and minimize the chance of failure and also complication. So guidelines is very important. So so that they're well versed with the guideline, they're smooth with the procedure. So this all are basically increasing the chance of a success in doing any procedure actually. So that's my advice now. That's why the steep learning in pediatric surgery is very long compared to adult surgery. After you pass as pediatric surgeon, you probably need at least 5 to 10 years to be able to do good in doing basically basic the bread and butter of cases in pediatric surgery, because everything is so small, right? So that's why you need a steep learning to master this pediatric surgery. I think when I was a young kid, my ambitions, I always want to be a teacher. Even now, I'm a teacher as well. I'm not only working here, but also involved in teaching master student, undergraduate medical student, and also postgraduate medical student, and also teaching post basic nurses. So I think being a doctor, you cannot run away from teaching. So it's the field that I like to do. I enjoy doing myself. Yeah, but most of the time I'm not getting any pay, but I just enjoy and like to do that. So yeah, I think medicine is one of the best fields that that you can basically how to say, you can help anyone else, not only by treating a patient, but also by teaching. Yeah, of course, this pandemic has really affected us very much. I think this is the second year it happened, right? Because of this pandemic, and then so many staff, are involved in the COVID management. Especially the medical officers and the anesthetists, so they're involved in managing COVID. So we stopped doing our elective surgery. Since last year we have to stop intermittently. When the first spike, the second spike of the peak of the pandemic. Because of that, our patients that waiting for surgery has really increased in numbers. So we only had to do the emergency and cancer patients. So we totally stopped doing the purely elective surgery like complex urology, hypospadias, and the daycare. Our daycare patients also are getting more and more. So in fact, overall total number in our hospital itself, we have more than 1,000 patients that require surgery. So how this pandemic has affected us so much. So we hope by the numbers in COVID in Malaysia are still very high, even though majority of them, 97-98% of them are category 1 and 2. But because of the staff involvement in managing the COVID, so we are quite badly affected in terms of the surgery that we had to stop doing, and our patients are just waiting. Hopefully by next year January we can inshallah we'll be back to normal, and we can get our elective OT again, and we just have to finish off all the cases. I'm sure it will take years, right, to finish the numbers. I just share with you that the problem with pediatric surgery, is some areas very subspecialized. You need to be well trained in the specialty, like in urology, complex urology, or hepatobiliary, and in Malaysia, not many. We don't have that many senior consultants in pediatric surgery. In fact, our total numbers of pediatric surgeon, we only have like 49 in our public hospital pediatric surgeon to cater for the 32 million population. So that's very, very little. But we could cater the general cases of pediatric surgery, but the subspecialty is very, very difficult. So something that we need to do something about it lah.